Welcome to the Better Never Ends podcast. We've made it our mission to share with you the expertise and wisdom of role models and leading experts in their field, teaching us about how we can be better, telling stories about their journey to better, inspiring you to discover yours. Today we are welcoming Alexandra Orfanides. She is a hypermobility specialist osteopath. Although from our early conversation, the osteopathness is perhaps not as relevant as it used to be, certainly when you're comparing across different healthcare providers such as physios, osteopaths, chiropractors. We've already agreed that we think they're more similar than they are different these days. I was introduced to Alex by someone that we both know, and they said that I should check out her stuff and she might be a good podcast guest. I think I scrolled, not as far down as we're suggesting that you scroll already, but I scrolled a bit down, checked out some of the posts, and they are really quite fantastic and really engaging content. So I'm looking forward to talking today about the impact and the meaning of hypermobility. And it really tunes into what we as a podcast set out to do right at the beginning, which is have conversations about health-related problems that are often brought up in physio, osteopath, chiropractic sessions. And it's also leaning on perhaps a rebrand that we're looking at here. Ultimately, I am a physiotherapist and we speak to healthcare providers. And going forwards, our topics are likely going to be a bit more focused on appealing to the allied health professional world. So this is a great place to start today. Here's a kind of unofficial rebranding, launching of that. So I'll introduce Alex now to talk a bit about herself and a bit about the things that she does. But first I want to really get into what hypermobility is and what it isn't. So help us uncover that.
Cool. I'm so excited to be on here today and talking about this with you. So hypermobility, it's a broad term. I actually did a very recent post about why I use the word hypermobility. It's very intentional in my content, and we'll get to that in a moment. But hypermobility is a characteristic. So connective tissue will have different degrees of mobility. Some connective tissue will be stiffer, some will be less stiff. And just like you can have hypermobility, you can have hypomobility. And somewhere in between those two phrases lies normal mobility as well. Now, hypermobility is a characteristic. So if a patient gets told, oh, you're hypermobile, and I can say that was the case with me growing up, that is not a diagnosis. That is just a descriptive term, which is describing something that has been observed in them. It's like, for example, how being tall can be a characteristic that someone has. You have people who are just tall. I'm tall. But it can also be a feature of a diagnosable condition, like certain hormonal disorders, which can affect people's height, for example. So hypermobility, it is literally just a description in that sense. Now, where it gets a little bit more nuanced is when we get into the diagnosis of connective tissue disorders. And hypermobility can be a feature and is a feature of many connective tissue disorders. The two most common are hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorder. And again, we'll get into the complications regarding the differences or potential overlap there. But they are two different terms that are currently used. And we have other types of Ehlers-Danlos syndromes. And we also have things like Marfan syndrome or low hEDS. So we have different types of connective tissue disorders. So it's connective tissue disorders involving hypermobile connective tissue is much bigger than just hEDS or HSD. And although those conditions make up the majority of people who we do see diagnosed with conditions involving hypermobile connective tissue, from my perspective, it just didn't feel right to make, my brand hEDS, HSD, HQ instead of hypermobility HQ, because I see patients who have Marfan syndrome sometimes, and it would feel very exclusionary to do that.
I also think it speaks a language that people understand intuitively. You say hypermobile, and even if you don't know the next detail of it, you can already imagine in your mind what that really entails. And I think that simplicity allows you to speak to more people who don't understand from the beginning, rather than alienating yourself by complicating the diagnosis.
Yeah, no, absolutely. And we'll get into more on kind of the management probably of these conditions and how it presents it later. But it's so important that early identification happens whenever possible, because we see that it makes a big difference. So even if that person who's maybe like found me on social media, maybe they're not able to access healthcare or helpful healthcare, if they at least know that, oh, I might be hypermobile, maybe I should be looking into this more, maybe I should keep trying to talk to my medical doctor about this, it gives them a leg up versus seeing some very specific diagnostic term which they might think doesn't apply to them.
Tell us about your journey into this world. I imagine it started off as realizing that you were hypermobile yourself.
Yeah, I was going to say like I was born. But no, for me, there's kind of two journeys. There's the one I went on, as an adult, starting to work with patients and having this really conscious realization of why my body's always been a certain way and why I work with patients in a certain way. But there's also the journey I've been on, which is my whole life. Like, I am hypermobile. I present with generalized joint hypermobility. I should hopefully have a diagnosis by end of the summer, which would be really exciting. But in terms of me as a professional, I was working with patients, and I started off my career actually working with elite sports people and professional athletes. So it was really lovely getting to see people do, with certain wonderful aspects of their health. A lot of these top athletes have won the genetic lottery in many ways. So to see that, and then because of just success at my work, having these more difficult cases referred to me. So I became known for working with complex and chronic and treatment-resistant injuries. And I'll never forget the day I put that in my Instagram bio, because I might as well have just put hypermobility because there's such a big overlap with complex, chronic, and treatment-resistant injuries and hypermobility. And that was me really saying without saying it, I work with people who are hypermobile. I then had a talk with a wonderful friend of mine who's also on social media. And I told her, I said, I love working with sports people because I do. I'm quite sporty myself. I love the, athlete management side of things and seeing what people are physically capable of and competitions and all that excitement. But I also love working with people who are just trying to make their bodies function for them. It's so rewarding helping people just be able to live their lives, whatever they want to do. So I spoke with her and I said, look, I'm thinking of pulling the trigger and changing, my bio to say hypermobile. And should I do that? She's like, Alex, you've been working with hypermobile patients for so long. It's your obsession. It's all you do. It's all you talk about. Yes, you should do that. So I finally that was when everything kind of changed. I started to talk pretty much exclusively about hypermobility. And it was, I think we were talking earlier about being a business owner and branding and stuff. And when you find the brand or the identity or the niche, whatever you want to call it, when you find the specialization that's right for you, it feels comfortable and you feel at home. So I just knew that was right for me, and we've been working with hypermobile patients ever since.
I had a similar situation where I was when I was starting my business and figuring out the brand and the name, and I already knew that at that point my why, my very reason for doing what I do was better never ends. I really love the striving for betterness, the growth mindset. And I'd already realised that, and I was saying, what do I then call it? What do I do? I want to call it Better. I think I want to call my brand Better, but that's already taken. Better.com was a lot ago stolen. So what do I do? And someone just said, why don't you just call it Better Never Ends? Like, that's what you do. That's not taken. It's like, yeah, okay. Why not? Because that is literally my why, the business's whole mindset writ large in the domain name. So again, I agree with you. It just felt comfortable to have it there. Yeah. It means sometimes people think the business is called Better Never Ends, which it's not. And that sometimes people kind of do, but I don't mind that. That's quite a nice misunderstanding of the brand. It still very much speaks our language. I was quite curious there when you said how excited you were, by the way, by your potential diagnosis. Why are you excited by that? What does that do to you?
It's something that I have it's an issue for every person who's hypermobile. This is a really complex problem, is finally having that answer, I guess, or that label. And for me, again, I'm someone who has dealt with serious health issues my whole life. I was replying to someone in a comment earlier today and talking about how when I was 3, I would have these horrible knee pains. My knees would ache. And one of my earliest memories is my mom tickling me and joking about cutting them off, because children have I don't have any children yet, but they have a strange sense of humor sometimes. And I thought that was hilarious. But like, I've always wondered, how does chronic pain from earliest memory kind of shape you or affect you? So it's something that has had a profound impact on my life. I've gotten to the point now where trying to finally get a diagnosis and get some answers feels right for me. And again, there's this pressure, I think, for everyone to kind of try to rush out and, get a diagnosis. But the reality is that sometimes a diagnosis doesn't lead to accessing better care. That's the disappointing reality that's frustrating that a lot of people deal with. However, a diagnosis should lead to better healthcare, and it should help keep the patient safe, and it should help that patient make better clinical decisions with their doctor. So that's why for me, just as I've, developed a few more issues with my own personal health, it's become something where I've just said, look, like this has to get done. And again, it's particularly difficult in the UK when it comes to a diagnosis because it's very, very challenging to go through the NHS. So I've had to say, what am I going to do with my finances this year? Is there money set aside for that? And it's been a year where I've been able to do it. But that's in part why it's been a bit delayed for me. As well, I will say that because of my work with patients in different countries, you start to learn about how healthcare works in different countries and in different ways. And every country is so different. If there's a niche thing I can put on my CV, it's having a vague understanding of healthcare in everywhere from like the Netherlands to India to Italy to different states in America. The variation in states in America is wild. And it's really interesting that when it comes to the UK or patients in the UK, if you get a diagnosis of what's classified as a developmental disorder, so this would be something like hypermobile Ehlers-Danlos syndrome. ADHD, interestingly, is also classified as a developmental disorder. Then health insurance companies can either offer to not cover you, or they can raise your rates significantly, or do all types of very negative things to people who have private health insurance policies. Versus, interestingly, in America, where there are a lot more protections in place because of, I believe it's the Obama Act that protects people there. So it becomes very much an individual and personal decision. And when people ask me, should I get a diagnosis, I always tell them, like, it's my job to say yes as your healthcare provider, because this is how healthcare systems operate, and I care about keeping you safe. And in theory, a diagnosis should keep you safe. But when it comes to that patient, having to choose between trying to fund it themselves in the UK, because there really are not pathways through the NHS, it's very, very difficult. Or, being under significant financial strain potentially because of that, it becomes a very complex decision that involves a human with different concerns and different priorities and, different things going on in their life. So it really is, it shouldn't be as problematic as it is, but I'm happy to finally, hopefully get some closure on that for me.
It sounds much more of a personal decision than I thought it would be, actually. Yeah. It sounds like one to weigh up the pros and cons for sure. And you touched on something that is absolutely, has always been a problem within MSK Physio as well, which is this chronic versus acute problem and whether they cover it on insurance or not. And it's never, ever made sense to me. Like, surely it's in the insurance company's best interest to have a chronic condition better treated and managed so they don't have to pay out for incredibly expensive joint replacements, for example. However, that's the limit they set on the policies, and it just seems like in the end, I'm sure other people manipulate them for their own benefit and to some degree, but with certain conditions that's difficult to do. Yeah. As I found out recently, my daughter has asthma and eczema, and particularly bad, in my opinion, acute flare of this. And the insurance company said, sorry, we don't cover chronic conditions. Yeah. And the NHS are just not equipped to manage it. We've been back 3 or 4 times to the GP. Really, nothing on the individual GP, but the structure just isn't there to support it.
Yeah, it's all a big mess. It's a huge problem. Even with basic, like things like, again, I say basic asthma is not basic, but my partner has asthma as well. And it should be something that we can manage well. And it's difficult. He's been surprised that, he's received some healthcare through his policy, but then they kick you off after a certain point. And now because it's chronic, good luck. Yeah. So it's, it really does, it differs depending on the country, the policy and everything. I will say as well, when it comes to diagnosis, it's also interesting how a diagnosis can affect access to healthcare, in that in the UK, there are no nice guidelines for hEDS and HSD, and we'll talk about those more, I'm sure, later. But the 2 most common hypermobility-related connective tissue disorders, there are no nice guidelines. So you're kind of at the mercy or luck of the doctor who you encounter as to whether or not you access care. So again, that patient asking, will a diagnosis help me access care? It depends who you see. I can't say. Whereas in countries like America, for example, a diagnosis will, if that person has an insurance policy, again, I'm not saying American healthcare is great. We all know there are many issues with it, but if they have a reasonable insurance policy and they have access to some money, it can help them access care. And specifically, what's very interesting in America is that hEDS is treated differently than HSD. So there are some patients who will have an hEDS diagnosis, and because of that, and again, I'm not in, as much as I know a bit about healthcare systems, I'm sure there are many people who will know way more about the American healthcare system than me when it comes to this. But it's my understanding that if you have a diagnosis of hEDS, there's a specific billing code which can then be used to help patients access care. Whereas if you don't qualify for hEDS and you get HSD, which is not lesser in any way, and we can get into that in a second, but these patients will then not have a billing code essentially, so they can't access care.
Yes.
So it's all, this is why I love working with the actual muscle and joint pain issues in patients, because I hate this stuff, but these are the problems that people have to deal with in their day-to-day life.
And what are the differences between those two diagnoses whilst we're on that topic?
Oh dear. Okay, so hypermobile Ehlers-Danlos syndrome. Firstly, the diagnosis, like this diagnostic term has changed 4 times since I think it was the 80s. So we had like the Villefranche criteria, we had the previous one which called it hypermobile Ehlers-Danlos type 3 or something like that. Anyways, it has changed. I was born in 92, like in my lifetime, it's changed even a few times, right? So we have patients who have just been given different labels and it's all become very confusing. In 2017, these guidelines were released, the 2017 diagnostic guidelines for hEDS. And this specific set of diagnostic criteria is used right now to help a medical doctor decide if a patient qualifies for having a diagnosis of hEDS or not. The patients who are hypermobile, but who do not qualify or do not fit the diagnostic criteria for any other hypermobility-related connective tissue disorder, and who do not fit the hEDS diagnostic criteria, they end up being diagnosed with HSD. I describe it as the bucket for the people who don't fit in the hEDS bucket, because hEDS is a diagnosis of exclusion of all these other conditions, and HSD is a diagnostic bucket.
Exclusion of the exclusion.
It's an exclusion of an exclusion, exactly. There's a really big misconception that it is less than hEDS. That is not true at all. It is literally, the patients I have, some of the most affected patients have HSD as a diagnosis. And there are a lot of questions being asked about, does this differentiation make sense? Should we have one more inclusive hEDS diagnosis, which encapsulates the people who are getting HSD right now? Or should we potentially have more diagnoses? It'll be interesting to see how it goes in future. And the reason that we have this confusion is because we don't have a genetic marker to diagnose this stuff right now. That's why it's so confusing. But I hope I've explained to you a little bit of the difference between hEDS and HSD.
What are the clinical characteristics that you might see within the diagnostic criteria for hEDS?
Yeah. So the diagnostic criteria can be explained as really simply having 3 parts. So it's literally an A4 piece of paper. You could look it up. Part 1 is going through the Beighton scale. So we're looking at generalized joint hypermobility. The Beighton scale is problematic in and of itself. I did a whole podcast episode on it, but it's what we use and it's just how it is, okay? So with the Beighton scale, we're looking at people's thumbs, their pinkies, their elbows. You can already see we're looking mainly upper extremity, right? No, forward.
There we go. Look.
Yeah, this way.
Can you show us? Because it's super quick, right?
Yeah, we can do it together. Yeah. So my thumb is touching my forearm.
Yeah, mine's not.
Yeah. We're looking for elbow hyperextension. Again, it doesn't have to be huge, right? Elbow hyperextension normal range is 10 degrees. We're looking for more than that.
Okay.
We're looking for pinkies. My pinkies are not hypermobile. So the mistake people make is they look at the distal interphalangeal joint. So looking at that one at the end. We're not looking there. We're looking between this bone and this one, right? Mine don't go past 90, although it gets pretty close.
So I think mine's actually more than yours.
Yeah, it is more. My I think for me playing piano really affected my hand strength. Yeah. And we can talk about congenital and acquired hypermobility later because that's a whole thing. Yeah. But and then of course we have the knees, which would require me to stand up. But can you stand up and touch the floor? Am I to stand up? Okay. Cool. So the question is then, can you stand up and while keeping your knees straight? You can't see them, but locked out. Can you touch the floor with your palms flat?
Nearly.
Yeah, and then come back up. And then we're looking to see if that knee walks out. So again, we would just go behind the patient, put my hand there. You're feeling for that hyperextension again.
Yeah.
We're looking for just beyond normal parameters. You can get a goniometer out if you want, a protractor.
Yeah.
My bare minimum requirement is that people actually get up and assess patients. So your hand should be on the elbow, your hand should be on their knee.
So it's palpation as well as observation and measurement.
I think it helps. So there was a post someone else in this community did about how their orthopedic consultant, I think it was, described what they felt in the elbow as almost like two bones crashing together. So you get this, it's a different feeling because it's going past where it's meant to go as well. Palpation's particularly important for patients with any significant degree of body fat. So again, I've had many patients who end up being told, you're not hypermobile. And very often these will be patients who do have extra fat on them. But when you feel their joint, it's obvious, or when you look at them. And I do think a lot of times, unfortunately, the Beighton scale is done by people who are sitting behind a desk at a computer, who are kind of glancing up quickly and aren't really looking at that joint.
Or who don't do it enough, right?
Yep.
You just saw me immediately do the thumb wrong, right?
Yeah.
So it's people who don't do it enough to know it well enough to repeatably and reliably diagnose using the Beighton scale. And look, I've always kind of very flippantly gone through it because I don't know enough about it, and only when people ask, probably I would say. Otherwise, it's more like I would rather refer to someone like you if people are having problems, and I think that suits me better.
Yeah, it's kind of a niche thing. And again, with the Beighton scale, as you saw there, it's mostly upper extremities. So most of the points are in your arms. I see people who have very hypermobile ankles, hips, jaws, spine, and that's not really accounted for at all. The touching the floor point, again, people think it's hip hypermobility. It's really not. It's more to do with the length of your arms, probably in body proportion. I have a very long back and long arms, which makes it incredibly easy for me to get my hands down. So it is a problematic tool, but it's what we use at present. And I will say about the Beighton scale, it's very good at ruling people in. So if someone is scoring, again, there are different numbers depending on sex and age as per the 2017 guidelines. But if someone is scoring a 4 or a 5 on the Beighton scale, depending on their sex and age, they're demonstrating what's called generalized joint hypermobility. So what we are saying from that is that this person has hypermobile connective tissue throughout their body that's affecting their muscle and joint function. And that's something that a physiotherapist or an osteopath or a chiropractor can say. That is literally it's not a condition. It's not a disease process. It is just an observation of their hypermobility. So that's part A of the diagnostic criteria, is essentially the Beighton scale. And for people who are at the borderline, there's a couple other questions to see, were they able to do these things as a child? Should we include them or not? So the Beighton scale plus is what I call that first part of the form. The second part of the form is 12 characteristics. And again, there are some questions about why certain things were chosen and why certain things weren't. And as you and I know, healthcare is always in a flux. We're always refining things. There will be updated guidelines released next year, which hopefully will improve on some of the issues with the current guidelines. But the current set of characteristics, we're looking for pysogenic papules. That's one thing. So when the patient stands, if you look at their heel, do they have what I call it bubble wrap? So you'll see these little bubbles on the inside. They have to be weight bearing. So you have to have them put weight on their heel, or find another way to elicit that. But basically you're looking for these little bubbles. And it happens because the connective tissue that holds the calcaneal fat pad in, it's not sturdy enough to prevent it from sticking out.
And there's a huge load going through, huge load going through the heel.
Yeah. And people have them or they don't. And I love it because for a lot of people, because they've just coped for so long, sometimes it's hard to be like, is there something going on with me? Because even I just want to be chill. I just want to have a chill, nice time, So some days I'm like, am I really hypermobile? But when you look at these things that are very objective, when you look at these things that nobody can argue with you if you have pysogenic papules or not, it's really nice to have that almost just as like a reassuring thing for the patient to see and to be like, hey, I have all these bumps on the inside of my heels. My friend who's not hypermobile doesn't. I do have different stuff going on with my body. I think it's kind of a very validating thing for patients to get to see. And when I'm doing this criteria with patients, and again, I cannot diagnose patients. I do not diagnose patients. I am not a medical doctor. But what I will do is I will take this diagnostic criteria and I'll discuss it with the patient. I then give them the form and say, look, I think you should talk with your medical doctor about this. So that is the role that I play. But when going through this list, we have the pysogenic papules. We can do wrist sign and thumb sign together. So we're looking to see if the thumb and pinky overlap around the wrist. So you have to find the smallest part of that joint and look for that overlap there.
Mm-hmm.
Yeah. So we're looking for that bilaterally. And you can do it or you can't, right? So I see people too who do it down too low and stuff. It really has to be at that joint line which again goes back to making sure patients are seeing someone who knows this stuff cold. But that is called the wrist sign. And if the patient can do it bilaterally, then we consider them as having demonstrated that. There's also the thumb sign. So if you grab your thumb and it sticks out past the margin of your hand.
No.
Yep. So again, as people age, their ability to do these signs also will decrease. So I can still do it on my right, not to the same extent. This is my obvious side because, of course, I'm right hand dominant and I've had more stuff going on with my right hand. But age does affect some of these tests that we do in patients, which is really why I think we do in future need to further refine the diagnostic criteria for people of different ages. But that's another one. We're looking for atrophic scars in the absence of hemosidetic or papyricious scars like you see in other types of Ehlers-Danlos syndrome. To explain that simply, we're looking for scars that are slightly indented essentially, or when you run your finger over the scar feels indented. That suggests that it hasn't finished its healing process, that in atrophic, it hasn't properly smoothed out the whole way. Hemosidetic scars just have a certain color to them, and papyricious scars have a certain texture. And the reason that we don't want to see those is because they can be suggestive of other types of EDS. And again, this is why we need actual proper assessment of this. So I'll look at the patient, say, you see how this scar, when you run your finger along it, it goes in? Like, I want you to show your medical doctor that because they need to take a look at this. So just kind of helping the patient be able to better communicate. In terms of other criteria, you get into things like having a relatively large wingspan. So we're looking for certain numbers there for arm length relative to the rest of the body. There are 12 things. What are they? I can't even remember that. Oh, a small jaw. So a high or narrow palate or a history of dental overcrowding. So I have a small jaw. I had major jaw surgery where they cut through my entire maxilla and broke my mandible. So my lower and upper jaws were both surgically repaired. And anyone who's had that jaw surgery, like they should be assessing these people right away almost for this. So it's a list of 12 bits and bobs. And then you get to the part C of the criteria, which is, could this patient have another connective tissue disorder or something else causing their symptoms? Lupus is a great differential diagnosis, which gets missed sometimes. I'm always not in fear of lupus, but I'm always wary of things like lupus. Multiple sclerosis. There are many other disease presentations which can cause symptoms similar to what people with hEDS get. So we really need a medical doctor to be saying, look, I'm confident this patient has hEDS. I'm confident they're not presenting with anything else. That's that third box. And that's where I tell patients, this is the diagnosis of exclusion part. And this is why I want you to speak with your medical doctor about this.
So I have this term that I use for bendy patients. And I say, you're on the bendy end of normal. And I use it a lot because because I definitely don't. I mean, you're nervous yourself about diagnosing, right? You don't diagnose, so I don't want to diagnose either. Yep. So I say, if they show me some level of hypermobility, it's like you're definitely on the bendy end of normal. I will be considering that in the way that I program your exercises and how I give you advice. But if they're anything more extreme than that, I would essentially encourage them to see a specialist. And I think now that I've been introduced to you and you're in London, that specialist would become you.
Thank you.
But I guess there are some people who don't necessarily have someone they can access, although I know you do online work as well. At what point does the bendy end of normal turn into something that needs a bit more specialist care?
Oh, you've asked a difficult question. So firstly, you can do the Beighton scale and you'll be able to screen patients that way and get a pretty good gauge. Again, it's not perfect, but absolutely. If I had the time, I would just go from clinic to clinic and teach people how to do the Beighton scale, because then at least we'll catch the people who present with that, right? And then they can know they're hypermobile. And then you can very clearly feel really confident in altering their care if needed to help them, right? So you absolutely can do that for sure. But when it comes to how do we know which patients to be careful with, this is where it comes down to a few things. So firstly, we have to appreciate that the degree of someone's hypermobility or their joint hypermobility does not directly correspond to their symptom severity. So I will have some patients who have horrific knee pain or just really a lot of serious issues going on. And sometimes they're not the most mobile patients, the patients with the banana knees, the really, really hyperextended ones. Sometimes they will be someone that for whatever reason, their symptoms seem to be be less pronounced. And I think we have to start to think about individual and anatomical variations or variation in nervous system function. Do some people feel things more for different reasons or less? But it absolutely, someone's hypermobility does not denote their degree of symptom severity, I would say. So that's something I try to bear in mind, just because I used to also think like, oh, it's the really bendy people I have to watch out for. And that is not the case. But what I will also say is that I think the thing that I try and do with patients to keep myself safe, because I'm a very risk-averse person and a very risk-sensitive person because of some health things I've gone through personally and with my family. And I just, all good healthcare providers care about their patients ultimately and keeping them safe at the end of the day. So I will do a comprehensive medical history, going through things like cardiovascular health. So one of the big questions I always ask about patients' cardiovascular health is, do you have a history of any early deaths in your family, or has anyone had any heart issues that seem kind of weird, or things that you aren't sure about in that way? And I do that because it's very easy for a patient if I say like, any family history, and they'll just be like, no, it's all good. They won't really think about it. But what I want to know is, could there be anything there? Because that will help to affect my risk tolerance for that patient. So every patient I see, there's a little like meter in my head going back and forth about how stressed I am about the patient. So that certainly affects it. As well, when it comes to how we, manage patients from a risk perspective, there are certain things that make me less stressed. So to give you an example of this, if a patient has had an ultrasound of their heart, so an echo and an electrical study, that helps me to feel more confident that they don't have any cardiovascular manifestations. Because in terms of things that can be life-threatening or of serious consequences, that is one of the tissues which can be affected in some cases in people who are hypermobile, most notably with people who have another type of Ehlers-Danlos syndrome called vascular ADS. But that's something, if a patient tells me, Alex, I had an echo, I had an EEG, it's all good, like no abnormalities detected, and I get them to send me the reports, by the way, because I want to see them, that helps me to be less stressed. Another thing, and again, it comes down to clinical management and differences, geographical differences. In America, it's very common for patients to have genetic testing done. If they have insurance and access to healthcare, part of that will be having genetic testing done to rule out other hypermobility related connective tissue disorders. So when I do see patients from America, they'll tell me sometimes, Alex, I've had this, I saw a geneticist, I had genetic testing done, I don't have any other type of EDS. And I'm like, that's great. Or any other type of connective tissue disorder like Marfan syndrome. And I say, that's excellent. That helps me feel more confident that you do have hEDS. Whereas when I'm working with patients who are UK based, it's very rare to have genetic testing. And again, it's not necessarily that that's the wrong clinical decision. You can make arguments both ways for it. But I'm the type of person where I just like more information. I think that it helps people to, I think that understanding is always a good thing. And genetic testing is a component of that. It's just, of course, the price is prohibitive and people would have to do it, self-funding in the UK for the most part.
Are there any other questions then? It sounds like the medical history is particularly detailed and specific. So what other questions would you ask someone at that stage?
Other questions? I'm looking at things like, what else? Eye issues scare me. So I've had eye surgery. I've had so many serious things happen. Like I know I look well, but I've had like the wildest personal experience. But I'm asking patients about their ears, eyes, nose, and throat. And that's always something I question about because people with hEDS, and when I say hEDS, it's hEDS/HSD. I think it's nonsense.
We can umbrella term for that.
Yeah, can we umbrella term? Okay. But people with hEDS or HSD, they are at greater risk of high myopia. So high myopia is classified as a nearsightedness of negative, I believe it's -4 is the cutoff or higher. And people who have that are at greater risk of retinal detachment. And retinal detachment is a medical emergency again. So when I see patients and they're like, Alex, my vision is -7.5, which is what mine was, by the way. I will ask them, I say, has your medical doctor, your optician, or your ophthalmologist, has anyone ever spoken with you about the risk of retinal detachment? And they're just like, no. And I say, do you know the signs and symptoms of retinal detachment? And they say, no. So we have a little chat about that. So it comes down to doing a very comprehensive and detailed medical history from a place of pretty in-depth knowledge and also of a low risk tolerance.
So if someone has had eye problems or specifically retinal detachment, would that start to raise your index of suspicion around a diagnosis that should then be investigated?
Yeah, I think there are some patients who will end up right now getting a diagnosis of hEDS where they may go on in future when we have more genetic markers and information to maybe have something different. So there are some people, there's one dear friend of mine in particular on social media, and she has a diagnosis of hEDS and she has very serious eye issues. And I wonder if in future she'll be found to have some subtype or
Yeah.
some new type of hEDS, if we keep people in that category. But yeah, people who have eye issues which are not managed or who are not aware of the risk of that, people who are experiencing dysphagia. So gastroparesis is a very serious consequence of HEDS/HSD for some people. And after the musculoskeletal system, the gastrointestinal system is the bodily system that I tend to see the most problems with in patients.
I was going to ask you about this because
Yeah.
my limited knowledge of this subject was partially increased early in my career when I went on an evening course where they spoke about it, and I remember them speaking a lot about the gut and about the skin. So glad that you can fill in the gaps, because that's probably where my memory stops, or maybe bruises easily, and yeah, some kind of gut problems. But yeah, fill in the gaps with
Cool.
my forgetfulness.
Let's talk about hypermobility and the gut. And I have a whole podcast episode on this as well. So when it comes to hypermobility and gut function, from a keeping patients safe perspective, the questions I'm asking are, I start by asking patients, tell me about your relationship with food. The reason I do this is because the prevalence of behaviors relating to disordered eating or diagnosable conditions relating to disordered eating is very high in people with HEDS and HSD. So it's really important to be sensitive always around questioning. So I'll ask patients, tell me about your relationship with food. Occasionally I'll get patients who are, they'll just kind of be a bit confused why I'm asking that. And they'll be like, oh, it's all good. I eat everything, normal bathroom habits, all good. And those patients I feel reassured by, because we know that their gut seems to not be as affected, or at least isn't as affected right now, because things can always change. But when I have patients who tell me things like, I'm struggling to eat, or I've lost weight recently, or the most concerning thing would be I have patients sometimes who will tell me, Alex, I'm sick after eating. And when these patients tell me I'm sick after eating, but it's hours after I've eaten and the food's not digested, for me, that's like, there's a panic button in my brain. I'm like, red flag, red flag, red flag. Because what that suggests is that their gastric dysmotility, so dysmotility means the movement of that gut, is so impaired that their food is just sitting in their stomach. It's not moving down. And then they're being sick later because of it. So gastroparesis, it's like the word paralyzed. It means that the gut is not moving, and that is deeply concerning. So those are the patients where I would do immediate gastroenterology referral. If it can be done privately, if it can't be done privately, I would write the best letter I possibly can to their NHS doctor. And I would try and coach the patient and explain to them, like, you need to make sure your doctor understands this. And this is why this is a flag for this. And I always try to, I call it completing the circle. And I tell the patient, like, if your doctor does not help you, tell me, because then I have to try and figure out the next step. Like, please let me know what happens, because I really do care about their outcomes. So yeah, gastroparesis is very, very serious. In terms of other things that are serious, because as you know, the gut is a long tube. I talk with every patient about bowel movements. We have to. It is something which I think is not discussed enough. And it's incredibly important because it's really hard. I see lots of young people who have issues with using the toilet, and it's so difficult and so embarrassing, but it's also important for your health. So yeah, these will be people who will report in some instances, periods of weeks of constipation. This is something I've only started recently talking about, but when I was 15 once, I went 3 weeks without using the toilet. I was never told how serious that was. I was never told I could have had my, colon rupture or, serious health issues potentially from that. And the fact that there was no gastroenterology referral or follow-up, despite me having a family history, again, of gut issues, is concerning. So when I see patients who tell me, Alex, I'm having really serious constipation issues and it's been days or weeks, I always ask, what's your longest period you've ever gone? And they tell me that. I, again, will do a little prioritization thing in my brain where I'm like, okay, this person, yes, I know their neck hurts, but we need to sort their gut. And I will tell them, I'm like, look, I'm happy to see you for your muscle and joint pain, but I'm really concerned about your gut. We need to get this sorted. On the other end of that spectrum, we have people, and sometimes people have both. So sometimes people have too much gastric motility, sometimes they have too little. So the people who have too much, again, with those patients that are going to the toilet, 4, 5, 6, 10 times a day, they're having to do that. That is concerning, again, long term. That is not healthy gut function. And it's something which can be embarrassing. It can be disabling and is disabling for people. These are often patients in their 20s or 30s or 40s who just want to go out with their friends and have a normal life. So in those instances, I'm starting to think of what could we be missing here? What could be causing this? And I will often kind of screen the patient. Again, there's no formal screening questionnaire for this as far as I know, but I'll start to ask the patient about potential food sensitivities or things relating to histamine, and kind of we go down the mast cell activation pathway. And again, not everyone has MCAS, and there's a lot of current discussion and disagreement by medical researchers about what we're going to classify as MCAS and what isn't, what's maybe just histamine intolerance, if you want to call it that. But it's very important that this is identified because it can really affect people's health in serious ways.
It sounds like just some very direct but important and broad questions around someone's overall health, which is becoming increasingly clear as beneficial in a general physiotherapy assessment. And this is just a tiny bit more detailed, actually. Like certain parts is very much more detailed, but it's just delving that little bit deeper about what's going on. What else do you ask then? Clearly more.
There's a lot. I do ask about dental health a lot. So I worked in a dental practice for 2 years, doing HR and marketing, but I got to run their CPD evenings, their study events for other professionals. And I was lucky enough to just get to sit in on them. So I've sat in on a strange number of talks by incredible dental professionals in the UK. And research is very clearly showing that poor dental health and gingivitis, if we use that as an example. So gingivitis is simply inflamed gums. If your teeth bleed when you floss them, you pretty much have gingivitis. Again, I'm not a dentist. I'm not diagnosing anyone with that, but that is not what gum health should be. So with patients, again, people don't realize how important teeth are for your life. They're how we talk, they're how we eat, they're how we smile. And with patients, I will be asking them, do you have a history of a lot of cavities that, these will be patients who are trying their best, but no matter what they do, it's not good enough. And they are not having good dental health. And sometimes there can be reasons why this is occurring. Sometimes it comes down to the dental professionals not educating the patient enough and talking clearly enough with them. Sometimes there's a type of Ehlers-Danlos syndrome called periodontal EDS. So it could even be that their connective tissue disorder is really affecting their teeth and so on. But again, even just from a mental health perspective and having a positive relationship with healthcare professionals, it's really sad when people who are hypermobile see dental professionals and are criticized for being too sensitive, because we know, based on research, that people with hEDS and HSD are more likely to have a muted or a lack of a response to local anesthetic. So these will be people who don't go numb at the dentist. And then this creates this environment where they're starting to be literally traumatized through seeking healthcare, through doing the right thing, going to their dentist. They're not having any numbing, and it's incredibly painful to have dental procedures and not have numbing. And that starts to kind of have this cascade of negative healthcare interactions. So a lot of what I do ultimately, I think, in terms of keeping patients safe, is trying to help them have more positive healthcare interactions. Because as much as I get very, very frustrated with any healthcare professional who I think is not doing a good enough job at what they should be doing, I also, I want to help patients be able to access healthcare through people and have positive healthcare experiences with all of the wonderful healthcare professionals who are doing a great job. So it's trying to manage a lot of complex stuff.
Is there anything else you think we should know around the subjective, any of those things that raise your index of suspicion, that think, I need to help them here because this isn't quite right? Anything else?
I think in terms of things I think that physios should know. So when you do a medical history with a patient, I always ask about childhood sports and history of pain in childhood. I want to know about people's childhood. There's this idea of growing pains. I'm not sure how much you've read into it, but it's very, very questionable in terms of whether or not it exists. I personally don't think growing pains exist because the patients I see who have growing pains, firstly, they do not fit in line with the NHS description of what growing pains should be. The pain will often be within the joint itself and not within the bone. Secondly, these will be people who will have had this pain throughout their childhood. So if we're trying to attribute it to a growth spurt, again, why are they having chronic pain from age 3 through their whole life until they get old enough to just be told, oh, well, it's because of your posture, it's because you're using your phone, it's because you're studying, it's because you're pregnant, right? So it evolves from growing pains into chronic pain. Also, there was a brilliant, it's a systematic review, I believe, done recently. I did a carousel post on it, which really looked in depth at all of the studies on growing pain. And there is no real clinical evidence to support a diagnosis of growing pains. So it's shocking that a diagnosis is made so often without any clear diagnostic criteria, without any clear actual evidence of it even making sense from a physiological perspective. So there are a lot of things I can kind of find ways to deal with, and my work is stressful. I do feel, if I sound stressed, like it is stress inducing dealing with all these complex issues. But the one thing that really frustrates me more than anything is when children have chronic pain normalized, because what you do to that young hypermobile child when you tell them, oh, it's growing pains, stop being so sensitive, just get on with it, you need to stop complaining, is you are literally negating and invalidating their physical experience of their body. And these will then be the people who go on to potentially in future have more serious health issues. Maybe they're having issues, like we said earlier, with being sick or not using the toilet or different serious issues. And they'll think, oh, I don't want to be a problem, it's just normal. So I think that is the single biggest thing, is I would be asking people about their childhood experience of their body, their childhood pain, and whether any was present. Now, I do want to say that not everyone will have pain in childhood. There are many people who get diagnosed with hEDS or HSD who won't have symptoms until later in life, and that in no way means that they should not have that diagnosis. It can present differently and affect different people in different ways. But I think the growing pains one is a super easy question, just like, did you have growing pains? I find is an easy one to ask, and that definitely raises my index of suspicion. I would say another question I always ask is like, do you have a history of chronic childhood infections? Because again, research is very much still emerging. I would love to have more research done, but unfortunately this topic doesn't generate that much interest at present, but hopefully that will change in future. But patients who have a history of chronic urinary tract infections, which are incredibly painful, having been someone who struggled with that, chronic thrush, chronic eye infections, chronic ear infections, these types of things, serious high fevers, these types of serious illnesses, again, they get missed and they get dismissed. Oh, it's just a UTI. Oh, it's just an ear infection. There's nothing just about it.
It's that phrase, isn't it? It's so dismissive.
It makes me furious. So yeah, it's really taking the time to kind of get down into the nitty gritty of that medical history, to then assess that patient, all the while looking from a risk tolerance perspective. The last thing I'd like to say, if you don't mind me saying one more thing, is just to be, I think it's so important to be aware of the overlap of various neurodivergent presentations and hEDS and HSD. There is a lot of research suggesting a very strong correlation between things like ADHD and hEDS and HSD. And these will be things which affect a patient's interaction with healthcare systems long term. For example, I'm not someone who's diagnosed, but people have suggested that I might potentially fit into the category of someone having ADHD. And one struggle I really had when I was a patient having physiotherapy when I was 16 for my shoulder pain was that I would struggle to remember exercises. They would show me the exercise, I'd be watching, I'd be paying attention, I'd be trying to listen. And whether this is ADHD or developmental coordination disorder or something else, who knows, but I would really struggle to remember the exercise. So before I really knew I was hypermobile, and before I was even working in this field, I was always like, they need to give support. Like, they need to be giving handouts or letting people take videos, or there needs to be some type of support here. And the reason, again, that I just say this is so important is that these patients who do have things like ADHD, if you show them a bunch of exercises real quick and just say like, bye, and send them out the door, they're not going to be able to do that. If you give them programs that are boring, they're just not going to do them. Like, I'm the type of person, I don't do boring things. So I think that there's this idea that with chronic pain, and I say this because all of this stuff, it is serious. Like, it all sucks. But there's this idea that with patients with chronic pain and serious health issues, you have to do boring things. And the opposite is true. Because when life is hard and things are down, like if everything's a struggle, you need to give, like, people need to have ways to really reclaim control of their body and feel at home in their body and find ways to feel like they're making progress, and even if I can say enjoying, or potentially like finding ways to just get through that journey. So finding ways to work with patients, neurodivergent or variations in how they think, instead of like working against it, is critical to the management of a lot of people with hEDS and HSD.
I would just say that should be a fundamental skill that all clinicians learn. How to make a rehab program interactive, enjoyable, or at least appreciate the value of, and therefore they engage with.
We need more fun. The world needs more fun.
I agree.
So I don't know if you've heard of gamification, but it's this idea, gamification, making everything in a game. Absolutely. And then habit stacking. I will never ask a patient to do something just random who has time. Where is this magical time everyone gets? So I find something else, stack it on top. Yeah, these should be clear things, and clear outcome measures as well. So I get stressed sometimes because I'll tell the patient an outcome measure and I'm like, oh, this is a bit, that's a tight timeline, but we're going to see, and it puts pressure on me, but it also means the patient can sense that, and they're like, this is serious, let's see what we can do
on both sides. I think there's a really powerful message there, and that's one of the reasons I continue to use numbers regularly, is because I want to make sure that my job is doing what it should be doing. I want to make sure I'm doing a good job. So yeah, I agree. All of this stuff should be just fundamental. This is now just universal skills that people should be considering as clinicians. Bruising, then, is this a myth? Is this a thing?
No, it's a thing. But again, not everyone who has HEDS or HSD will necessarily present with profound bruising, and some people who present with it's very concerning. So I'm going to take you through my bruising assessment real quick. Okay, so when you're looking at bruising, there's a couple of key things, right? So one, we always have to be aware of abuse. And I just say that because people who are disabled or have chronic illnesses sometimes are at increased risk of abuse. So finding, if it's safe and appropriate with the patient, talking about how'd that happen, just trying to sort that out is important. What you will get a lot from people with HEDS or HSD is, I don't know. And they genuinely will not know. I can say that as someone who gets bruises and I have no idea where they've come from. And that is the honest answer. As well, though, what we need to be looking at is where are the bruises occurring? So when I see patients and they have bruises, and they can be quite serious bruises on parts of their bodies, but they're parts that they could have reasonably bumped into something with, the outside of the arm, the thigh, like some place reasonable. I say, in my head, I'm just saying that's okay for now. We're going to keep an eye on it, but I'm not too stressed about that right now. When I see patients who have bruising in places which don't make sense, so they're having bruises on like the tops of their shoulders or their neck or their inner thighs or something like that, that's when my index of suspicion starts to creep up. And I'm just saying, I don't like how this patient bruises. And then what I'm doing is looking at their diagnosis. So I will always record a diagnosis in a patient file as HEDS or HSD diagnosed in the absence of genetic testing or in the presence. And if that patient hasn't had genetic testing, maybe that's a path we go down. Maybe it's a referral back to a medical doctor. And by the way, they should have medical doctors supporting them the whole time, just to be clear. But yeah, that's kind of how I manage that in terms of bruising.
So we're probably getting to the point now where people are asking the question now on the other side, well, what do I do with this person? Now I've got an idea that they've got hypermobility that might be a factor in their management. So how do we then, beyond the diagnostic side of it, how do we help the person?
Yeah, I would say step one is literally just being... I think clear communication is key. So explaining what you can do and what you cannot do. So explaining, look, I cannot diagnose you, as we said, but being that potentially that referral person or helping direct that patient to ideally medical doctors who can. But I think the second step is looking at what you can help with. So if you're someone who is able to, in our profession, treat muscle and joint pain safely, of course, you have to have an understanding of how hypermobility can affect that, which I'm guessing we might get into in a minute, but trying to find the things that you can make a difference with. So, for example, for me, when I'm looking at a patient, I like to look for things that are either really affecting their quality of life. So things that are very serious or disabling. So, for example, headaches of a disabling intensity, they're difficult to treat, but if we can make any progress, that means a lot to that patient. So that's a challenging thing, which I will prioritize sometimes just because of how much it's affecting that patient, but also looking for what I call like low-hanging fruit or things that are easier. So if that patient has a lot of knee pain and their knees hyperextend, and I notice that they, I ask them, when you're at home and you're seated on the couch, like, how are you sitting? And they're like, yeah, I put my feet up on a footstool and their knees are just going to be hanging down like this. I have a talk with them and I'm like, pull that footstool closer because it'll prevent your knees from hyperextending, or put a pillow under your knees or the family dog or whatever. So those little strategic interventions can make a big difference. I talk about something that people could literally look at my content and immediately start doing with these patients is finding positions of supported or true rest. So for example, I'm sitting right now and I'm fine, don't worry. But if I sat here for long enough, my neck would start to hurt. Why? Because my shoulder is hypermobile. So the ligaments in my shoulder are too stretchy. What happens there? The weight of my arm, I have long arms and they have some muscle on them, so they're a bit heavy. But even if they weren't, they still have weight. It will start to pull down. And you get this feeling of ligamentous sag or creep. And you can feel it. It doesn't feel right in the joint. One of my first viral videos on TikTok, I talked about how my shoulder felt homeless. So I would see the physio when I was 16. I'm like, my shoulder feels homeless. And she's like, is it in pain? I don't know. It feels homeless. That's what I kept insisting on. But it will feel not quite in place. And what I would encourage if I was the patient, I would say, when you're at home, when you're resting, you have to be resting. Your musculoskeletal system has to be resting. And for you, because you're different, this is going to look different than it looks for other people. Sitting like a normal person isn't going to help you rest. So I would have the patient grab a pillow, grab a blanket, this type of thing, and stack up a support like that, because now we're just taking that weight of the arm and putting it on the pillow.
Basically putting it in an abducted, supported position. Yeah.
Patients will be different. So you'll have some patients sometimes who have certain other presentations where they might find that their arm height needs to be lower than this. But I tell them, I'm like, play around with it. You can take this away. It's free. You're at home. You can try this. I like quite a high support, okay? But it's being able to play around with things. I also, something that became quite popular on social media was the towel trick. So rolling up a towel, this would be a perfect blanket, putting it around your neck just to make a little support, because my head is heavy. And people will sometimes think that having a heavy head or having to always sit with your head on your hand or that type of thing, people will think that it's suggestive or indicative of things like atlantoaxial instability and cervical cranial instability. And the thing is, although it can certainly present in patients who have those, and those are just terms for a very specific kind of instability in a specific part of the patient's neck, it will happen for the most part to anyone whose neck is hypermobile. So what I would do if we were going to have a 8-hour podcast is I take this blanket, I'd roll it up so we get a nice cylinder, wrap it around, and then here, if I take my hair clip out, I could lean back and I would be supported from the back. I'd be supported from the back. And then I would also be supported and lifted from the sides as well.
I really like this idea of proper rest. Actually, that's not something I think I've considered enough in my practice in this context, because I definitely think about it in an exercise sense. Mm-hmm. When you're resting and recovering, do it properly. Nail your rest. You only benefit from the training you recover from. This kind of language is very regular in the way I speak. But actually, it makes complete sense for someone who is hypermobile. They don't have the same stiffness in their joints. Their muscles, perhaps at this stage, definitely aren't strong enough, but will never be strong enough to be fully able to cope the way someone else's might. Then you need to adapt. I like it. I really like this idea of adapting the world around you in order to facilitate your general level of comfort, rather than just trying to force it and just tough through it. I don't think that's the right mentality for a chronic pain situation, which is ultimately what this often is. It's a chronic pain situation.
Absolutely. And it's interesting for me. It really came through my work with professional athletes, because they're obsessed with resting and recovery. And then that just let me become obsessed with resting and recovery. And that's something, you're not going to hurt a patient doing that. If you teach patients ways to support their body, there is no harm that's going to come of telling a patient to do this. So for the healthcare professional, the physio or osteopath or whatever, who's nervous to work with a patient who's hypermobile, helping them find ways just to literally sit in a rested position is key. So I do have days once in a while now. It used to be all the time, but I will have bad neck pain and a bad headache. And I get home, go to my couch, get all my pillows and props out and set myself up. It looks ridiculous, but both sides in this, because it lets my neck just deload in a way which helps me actually rest it. And I think it comes down to having an understanding of the anatomy. So again, talk about that shoulder. What I think is getting pulled on is the nerve. Neural tissue does not stretch. So it's getting inappropriately tensioned in a sustained way. And finding ways just to give a break, it's so relieving. So no, absolutely. I'm a huge fan of, like as you said, rest and recovery in strategic and effective ways.
Well, it's almost the opposite of, we all start to get really paranoid about like bracing and supports about, are we just allowing the muscles to waste away and not do their job? And there is a truth to that, in that within activity, if we over brace, over support, and basically the muscles potentially will atrophy, and therefore it's almost kicking the can down the road. But this is like rest. It's just optimizing rest in a better way. And I really like that, because that's when we should be feeling relaxed. And I mean, it's the same as like sitting, right? People think that this obsession with perfect posture still exists within our society way too much, but it's not. It's about comfort. Like, be comfortable, allow the chair to do its job.
Rest like a queen. Just embrace it. Be extra.
This is like the extreme version of that. Not even extreme, like the logical all-day version, not just the sitting at your desk version. This is really good.
The other thing I'll say is standing is really hard for a lot of people with HDS or HSD. So if someone tells me, I can walk for hours, but I find standing agonizing, again, there will be people where that's not the case, but for a lot of people, standing is hard. And that comes down often to dysautonomia, which we haven't touched on yet, but there's the autonomic nervous system. Dysautonomia just refers to a dysfunction of that. And we know that people who are hypermobile are at greater risk of conditions like postural orthostatic tachycardia syndrome, so POTS, orthostatic hypotension, which always gets forgotten about but does exist, and other conditions which can affect how blood is moved around your body. So these will be people, again, who they go home, they sit on the couch, their legs are down, and they're like, why am I not recovering? Dude, it's because all the blood is in your legs. So like I tell patients, you throw those legs up because we need to get some blood back into the rest of you. And again, going back to my work with professional athletes, one of the athletes I worked with had these Normatec boots, and I was on my feet all day. Like, I was working such long hours, traveling a lot. It was hard work. And I work a physical job, and I do a lot of different sports. And I use these boots, these compression boots. And now there are different brands, which is really exciting, at different price points as well, which is even more exciting. And I was like, why do these boots make me feel so magical? So every time I saw them, I'd be like, do you happen to have the boots out? Do you mind if I pop in them for a minute? But all that those boots are doing is they're just compressing your legs sequentially from your toes all the way up and helping with that venous return. That's what they're doing. So for people who experience blood pooling, which is really painful, genuinely, I forgot to wear my compression leggings I went to see a musical a couple months ago, and it feels like your leg is going to burst. Like, it feels like there's arrows like all inside your leg, and it's just this horrible, horrible pressure pain. But anyways, what those boots do is they just help with that recovery, or throwing your legs up, they help. So that's a really basic tip. Again, if someone's experiencing blood pooling, is just, hey, are you taking little breaks throughout the day to get your legs up?
And I guess this is what you mean about sometimes the walking's fine because the muscle pump is in action, but the standing, the muscles are not in action, so the pooling happens.
Absolutely. And that's one thing. It's very hard to find a solution to it. Putting on some muscle mass does seem to help, I think, because it just kind of adds mass to the leg. But even with me, so I've done a half marathon row. I do fitness classes, every week, multiple times a week. Like, I love my sports and physical activities, and luckily I'm able to do them right now. But if you ask me to stand in a passport queue for a long time, you're going to see me squatting on the floor. Like, I will drop down at a certain point. But realizing that and having that knowledge again, the reason that it helps me so much is when I go do these sports classes that I'm doing. when I go do,
just crashing into the light with my head here.
that's all right. But when I go do these classes that I do, and I do things like CrossFit, and again, I know it's controversial. You have to train your own way. Let's call it Alex Fit. I do my own version of these things, okay? But the coach will be talking to people in the class, and you'll see me just seated on the floor because I need to. That's how I'm recovering.
And this is we're nicely getting on some subjects I wanted to speak about here. Like, but very commonly, I'll speak to people who, you know, bend the end of normal, as I've described, who I described like you need to be stronger in order to handle the extra range that's in your joints at the moment. Whenever you're exercising or moving around, my wife's hypermobile, so I say it to her all the time. Your joints are just crashing into the end range all the time, and it's just they can't handle that stress in the end. Whereas if your muscular system is better suited to it, better coordinated, but also just stronger, can handle it, then you're offloading those connective tissues in your joint. So by the sounds of it, you've got a real handle on what it is for you personally, and no doubt for your clients as well. Is there any, please add some detail to my very rudimentary explanation of why strength-based training can help with people.
I would love to, and that's the topic of my workshop tomorrow, so this is perfect. No, so look, I have so many patients referred to me and they're told by their medical doctor, oh, if you just build muscle, everything will be fine. That is not true, firstly. So we have to be level about that. It will not fix everything magically. There are also some patients who can't, or where it's not safe for them. So these will be people, again, they will have certain, usually other diagnoses as well. But if I have a patient where they're having, for example, loss of consciousness routinely from their POTS, I'm going to be very careful with this, right? So it comes down to working closely with appropriate medical doctors as and when needed. But for the patient who's relatively well, they're not passing out, for them, they're able to kind of live their day-to-day life. These are people where exercise can and is ideally a life-changing intervention for a couple of reasons. Firstly, as you said, muscle mass can really help to control joint range of motion. People do not appreciate how problematic, and I'm so happy you picked up on it, compression is. So I will see patients classically with pain in the front of their hips. I think that's their femoral nerve being irritated from hyperflexion. These will be people who can put their leg up very high or almost behind their head, and people don't realize the problem with that. In fact, it's something I experienced because when I first started squatting, it was the whole, I don't know what words you can say on this podcast, but the bum to grass period. And so I was not going to the grass. I was going like through the soil. Okay, like we were going all the way down because my hips are so hypermobile that way. And the analogy I use with patients is if you have an accordion, you don't want to squish it so hard that you break it. And that's what we're doing with joints. Over compression is just as problematic in that end range as taking the joint too far as well into a range of motion where we're lengthening tissues. So both are equally problematic. In terms of approaching fitness as well, I think there's this whole idea that you have to do strength training. And yes, this is what my workshop is about tomorrow, but it doesn't have to be where you start. We start at the place that's right for the patient. So when I see a patient, for example, I will ask them firstly, what do you enjoy? Because again, as I said, with chronic health issues, like things are not so good. So we got to find ways to make things a little bit more bearable or ideally better. So I ask a patient, what do you enjoy? And if it's one of those patients who hates all types of physical activity, which is totally okay. I love my patients who are very into crafting and that's it. They're awesome. But I say, what do you hate the least? And then we go from there. That's step one. Step two is what can you access? Some patients will be like, oh, I have a magical indoor pool or some, random things. Like they'll have, access to an amazing gym, or their mom will have a reformer Pilates thing in her house that's down the road or something like that. So it's like, what can you access in terms of money, but also what can you access in terms of time? So that's also where I start when figuring out how to help patients exercise. I then also will always ask, and this is probably because of my sports background, because I swam to a pretty reasonable level and have always loved competitive sports, is what's your previous athletic experience? Like, what do you have expertise in? Because if I can find something, the patient can bring some skill or some expertise, and it helps to avoid potential injuries stemming from poor technique, right? So I kind of look at the patient like that. Then I'm also considering what injuries or concerns or problems do they have going on. If I have a patient who is presenting with a lot of chronic ankle sprains, which they've been told, oh, it's just ankle sprains. And as we said, there's nothing just about it. But if I have patients where ankle sprains are a current big issue, we're probably going to prioritize a balance and proprioception type program. because if they're not moving, that's still going to get them doing something, and we can stack other things on top later. Yeah.
And also stacking that upon their life, very easy to be
Exactly.
adding that into a waiting for the kettle to boil time situation, or every time you stand up, do it on one leg. There's I like that idea. I use it all the time. Just implement it or integrate it into your general life.
And it can be a family thing. I had a mom and her son the other day, and we made it kind of like a competition for them. So the more fun you make it and the more people you can recruit to do this stuff with you, the better, right? But yeah, figuring out where to start. So that would be like a balance and proprioception type situation. For me, I'm also a huge fan of steady state training and low intensity steady state training. So I actually do have a book on this. It's available on Amazon, Kindle Unlimited, but it focuses on how to take the principles of steady state training and make them accessible to people who can't do big blocks of 45 minutes or an hour or whatever. I got into this through my background with sports like swimming and just rowing a lot on a C2 machine. But this type of exercise is excellent in terms of improving people's systemic health. We increase the number of capillaries in muscle, which again, when you go to do that strength training program later, if you've laid down some of this, these physiological changes, it makes the strength gains probably more efficient theoretically, right? We see different types of effects in terms of the mitochondrial function and so on. So for patients where they, might be nervous of weights, or maybe they have a lot of joint instability. Maybe I'm nervous. There's a lot of good research supporting a steady state type training approach. And again, these will be patients where I have them get a chest strap heart rate monitor. We have talks, maybe even with their cardiologist, about what heart rate ranges are safe for them. But again, that's gamification. The patient gets to watch the little line, makes it fun.
I'm a proper data geek, so anything around that I love.
Patients love technical, fun things. Like, people like things that are interesting and fun. So yeah, we do steady state training. Some people will hate it. So some people do not like doing this type of activity. So I'll start with 3 rounds of 3 minutes with certain rest parameters. The program builds up all the way to 45 minutes or longer. So 22.5 minutes with like a 1 minute break and then that. But again, that would be what I call a very proficient level of steady state training. We start at the beginning, and there are certain rows for promotion, but also demotion, because these will be patients who have good weeks and bad weeks, or good days and bad days. And having that demotion in place is key, because I remember looking at exercise programs when I was really struggling and being like, oh, well, it's week 4, so I should be doing this. And it's like, no, you woke up today and you feel like garbage, so maybe you should be doing less.
Yeah, I actually think one of our special skills as clinicians is the ability to regress. PTs are fantastic, general strength and conditioning coaches, really great at progress, but we're used to it. People are limited, we have to modify, so we regress things backwards. And I think we shouldn't lose that when people do progress. We shouldn't lose that skill of holding people back or regressing when needed. So I think that kind of flare-up plan, that backup plan, is really good to talk about at the start as well, reminding them that progress is rarely linear. It's okay, it's just information. We're learning what your body can handle. There's no way we can predict everything that's going to happen here. And all is within a normal parameter of progress that you should.
And it comes back to, again, from my work with professional athletes, they are watched by their coaches like hawks at the top level of sport. Like, you are watching that athlete pretty closely when they train, and the results that these athletes get are exceptional in part. Of course, they have their skill and their hard work and whatever, but they have someone there to help them change things as and when needed. So I have this talk with my patients, and I'm like, look, you need to become your own coach.
Yeah.
Like,
I say the same thing.
Yeah.
I need to teach you how to be as good a physio as I am, but for you.
Exactly. And it's incredible what people do with the right support. So we haven't even got to strength training yet, but those are kind of, it doesn't have to be strength training. And for people who are sedentary, who start an aerobic exercise program, they will get some strength gains simply because they're using their muscles. So for people where, for whatever reason we want to start there, that's a great option. I do find anecdotally as well, because strength training takes time to see results, people will feel better faster if they start on a steady state type training. have always tried to have an erg, whether it be a rower or a bike or something in my flat, because when I feel cold, it's a way that I can affect. And by the way, the sensitivity to temperature or struggles with thermal regulation is a part of dysautonomia, which affects many people with hEDS and HSD. But for me, going on my bike is a way I can use my heart to force blood around my body to up my temperature, and I feel better the rest of the day. Sometimes with fatigue, it helps again, or even digestive issues. So for me, gastrointestinally, moving blood through my body, getting on my bike, moving my muscles a bit, saves me. And again, there are lots of reasons why you can try and argue that makes sense, but it just, movement helps your organs, which are also things which need to move. So movement helps things move. But yeah, when we get to strength training, finally, when it comes to supporting patients in strength training and programming for them, I think, again, as you said, helping people become their own coach is critical when they are dealing with complex issues. Helping people feel things. So these will be patients who struggle to feel things. They will feel, I like to joke, dead inside. So when I was in gym class growing up, we were doing all these stretches and movements. I felt nothing. I didn't know why we were doing anything. So going through with patients and asking them carefully, what do you feel when that happens? Using tactile cues. One of my favorite exercises that I learned through gymnastics lessons I'm doing with my gymnastics coach. And again, it shows how we all help each other. But a banded lat pull down done, it's just a slightly different way of doing it, but putting your hand on your lat as you do it helps that patient to feel if they're actually using their lats or not. So any tactile cues are really helpful with strength training. Again, going for just doing something. I think there's this whole idea that you have to follow these complex programs. When patients come see me and they've had programs made by other people, they're like 20 exercises. Yeah. Who has time for this? I don't even know what's like. Tell me about this. You clearly had some trauma.
I shake my head with this because it's just people. I don't know why they're doing it. Like, to me, it just means they don't really understand what they want to give. There's just, if I just throw everything at it, something will stick. And
yep.
I sometimes use that approach with different treatment modalities, like because I've got the time in order to do that, but not with exercise.
Yeah.
I'm not going to say, if I throw all these exercises, something's going to stick, because they just can't do that.
And then if you take someone who's hypermobile and can do ranges of motion they shouldn't be doing, or you're going to show the hypermobile patient something, they're going to do some interpretive dance, which is not the same thing, right? And I say that as that person who has done that as a patient. So yeah, there has to be a high degree of precision there. So I will have my patients video me. I'm very okay with people videoing me or even recording things. I do ask that they let me know ideally, but like I don't mind that as a healthcare provider myself.
So.
But yeah, and asking the patient too, I tell them, I'm like, if you get confused when you get home, take a video, send it to me, and I will just tell you if that looks okay. Once in a while, I say, stop, we'll sort this out next I see you. But having, again, it's that close management is what makes all the difference. I like to personally, for patients, do 2 lower extremity exercises, 2 kind of upper extremity. Again, they're looking toward kind of functional or compound movements eventually. But for me, it's very simple. People need to be able to get things off the floor. There are 2 ways to do that. You can either bend over, kind of a hip hinge, like a deadlift, or you can squat. Those are the only 2 ways you can really get down, is at least that I can think of. When it comes to upper body, we're looking at pushing and pulling, again, in a very simple sense. Can you push something? Can you push yourself up off the floor if needed? Can you get something out of a cupboard? And again, how far you take this depends on you. In part of my journey, I fell in love with ollie lifting. I love doing snatches sometimes. And yes, I know there's risk, but my worst injuries have happened from just existing. And if I get injured from lifting a heavy barbell, so be it at this point. But by doing those, for the people who are those sporty patients who get supported long-term, sometimes they can, or they will, or they are already doing sports at a high level, and you can help support them in doing them better longer term, which protects their mental health and protects their health, their health as an entirety long term.
I often say, injuries, niggles and tightnesses are the price you pay for living a healthy life.
Yeah.
And I'm here to help you get through that so you can carry on living a healthy life.
I know it sounds ridiculous, but I fell in love with Top Gear when I came to this country and the Grand Tour. And it's like, you see cars that just sit in a garage and never get used. What's the point? You need that person to go out there and have those adventures. And yes, some injuries will happen, and it's all about risk management and risk tolerance.
That's what I say all the time.
Yeah,
I can never zero risk.
Yep.
We're trying to reduce risk, and here's the things that can help you do it.
Absolutely. There are a few things I don't like from a risk perspective. So I will say contact sports, I'm very not in favor of them. My partner loves lacrosse. I hate it. If someone runs at you in a certain way, you're in trouble. So yeah, contact sports. Also with my patients who are hypermobile, I encourage them to be picky. So say that they're in a gym class situation, the floor's slippery. Maybe that day you just walk through the workout or you don't really do it. I can say I do that because for me, a catastrophic injury is not worth slipping on a gym floor during a workout I'm doing, right? So yeah, being really particular in how you train is key. And I always try and contextualize that in the framework of the idea of being an athlete versus just, oh, you have all these issues, you're disabled, you have chronic pain, we're going to do things this way. I say, look, let's tell me what your dreams are, and whatever that dream is, I'm going to tell you realistically, A, if I think it's possible, and B, how we can get there. And even if we don't get there, we're going to have a lot of progress and positive growth along the way.
Now, a lot of the people that you would be working with will have self-selected into yoga or something that's similar, for obvious reasons, right? And it's not necessarily that yoga improves flexibility, it's that flexible people tend to be very good at adopting yoga positions. What conversations do you have with people around that? Because I imagine many of the people with hypermobility will align with that, who will have tried it and realize they're quite good at it to some degree.
Yeah. Look, I'm not a no type of person when it comes to physical activity. There are some sports and activities I don't understand, but there are, yoga and Pilates are very popular in people who are hypermobile. Partly, I think, as well, because we do see it present more to a greater extent in females. And again, when it gets to diagnosis, the numbers are much higher as well in terms of people who are diagnosed with hEDS and HSD. But yeah, yoga and Pilates are two very common physical activities for these people. When it comes to patients who are doing yoga, we'll talk about just avoiding end range. So the problem, as you mentioned earlier, when you're hypermobile is that you can go too far. So we talk about, instead of doing that advanced posture, doing that kind of basic or beginner level. And again, here we're talking not about yoga as kind of a practice, because there's obviously yoga with the asanas and the prana and all the different things. We're talking just like the local gym yoga class type situation or yoga studio class. But going through with patients, and I will get a yoga mat out in my clinic room. We did this the other day, and I told the patient, show me your sun salutation and talk me through what you feel. And she literally took me through step by step. When I raise my arms up, my shoulder feels out of place. When I bend over, this happens. So again, kind of taking very much a troubleshooting approach to how you work with patients. I do think that there should be some caution with certain things. So in my early 20s, I did a lot of hot yin yoga, which is probably the worst thing you could do if you're hypermobile. But again, at that point, I needed a type of physical activity thing I could do. It was what was local to me. My mom was not well at the time, so that's why I really needed that outlet. And yoga for me really resonated because it helps you find your center. I think for me, it was critical from a mental health perspective. So for people who are hypermobile and dealing with a lot of health issues, again, I think that's why in part people get drawn to yoga, because it's a place to just exist and be. So for those patients, I could argue, like a lot of people do, and say, oh, yoga is bad for you, can't do that, that's done. Or I could say, hey, yoga is important to this patient. It's really helping them in a lot of ways. Can we modify it slightly? And that's where my breadth of sports experience, I'm not a specialist at anything, but I'm okay at quite a few things, really helps me, because I can say, okay, when you do Trikonasana, we need to talk about how you're positioning your body in this way. Or for Pilates, we can talk about different positions as well. The classic issue in Pilates is when people do the soap dish pose, or what we would call in gymnastics a hollow position. They're lifting their head up and their feet up off the floor. They'll get neck pain classically. And a lot of Pilates, not a lot, but some Pilates instructors or some people who prescribe these types of exercises, they will say, oh, that pain in your neck is your neck getting stronger. It's not. If it feels like the pain of injury, it's the pain of injury. So finding ways again and saying to that patient, hey, when you go to your reformer class, when they tell you to lift your neck up, maybe just let's not do that for right now. We can revisit that in future. We can see if that's possible later. But for now, if it's aggravating you, let's modify your practice to suit you.
Pragmatic.
Yeah, it's just complex problem solving.
Yeah. What have we not spoken about today that's important to this topic? And I know you've got a podcast, and this is what we'll, like, right at the end, well, in fact, let's say it now. I mean, I would direct anyone who's interested by this to your social media platforms.
Thank you.
Podcast, because clearly there's a lot more to be said on this topic. But what other big rocks should we speak about just to finish off today?
Yeah, I think the big thing is you can look really well and you can be well, but you can also have serious health issues. I think that's a really key thing to be aware of. Some of the patients I see, like my patients are all incredible people in so many ways, but if you looked at them for the most part, you wouldn't think they had anything going on for a lot of them. So I think just being aware that that patient who's working that really intense job or doing that like kind of super patient, they could be someone who's just coping really, I say coping well. You're coping well until you're no longer able to cope, right? So I think being aware that how someone presents may not match what's going on in terms of their health. I think as well, also just being aware that there is so much that musculoskeletal experts can do to help patients who are hypermobile. And even if you're not able to help that patient, just being aware that like, hey, just because I can't help you doesn't mean necessarily that maybe there won't be someone else who can. I refer patients sometimes. I have had cases where I haven't been able to get the clinical outcome I want. And there's nothing wrong with being direct and saying to the patient, look, we've tried this, we've tried this, we've tried this. Here's where we are. I want you to speak to this person and this person because I'm hoping they can help. And that's something which I think every healthcare profession desperately needs more of. And I think finally just having a sensitivity to this being a lifelong issue. So I will never do, and I know that most clinics won't do this, but I have worked in some clinics over the years who do pressured sales. I hate the idea of pressuring patients. So you have to do this many appointments for this many weeks, blah, 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 to get a result by, this many, this type of pressured sales environment. I just don't like it because these are people who it is a lifelong thing. There will be some patients who maybe can upfront see you more often for resolution or support of that shoulder injury. And I say support because getting that 100% clinical resolution is very difficult. And I would say potentially not even possible often a lot of times in people who are hypermobile, although a 95% resolution is fantastic and great and should be fought for. And, we should try to achieve that. But just being aware that these might be patients who would benefit more from a long-term approach where you try and get them more involved because they're in their body every day. They are usually really capable people. Yeah. And they will benefit so much from an approach which has that perspective in mind.
That's a style I love anyway, because it aligns with coaching. It's allowing that person to go away, try the thing, explore, experiment, come back with feedback and with notes to then go again. I think it really empowers the person to learn more about their body. We've spoken a lot about that introspection, figuring out what these things feel like. I think is an undervalued question in physio. How does that feel? What do you feel? Just encourage them to introspect and understand and analyze what it is that they are experiencing, so that when they move away from you in the end, which most people do, they've got more skills, they've got more understanding of what those feelings mean. I think that's why tech works so well, because it helps people learn the feeling. When I'm training like this hard, what does that mean in my body? Okay, so now I know when I'm out training, this is the rough heart rate zone I'm in, this is where I should be, this is how it actually is. So yeah, I am a big proponent of that. I think it really works well to sometimes be spreading those sessions out every 1 to 2 months, maybe even further for some people, which then allows sometimes a high price point of therapy to be much more digestible for a person. Up front, people often need a bit more intensive support to learn a bit faster, but it doesn't have to be that way. So I agree. I think there's lots of different ways without hard selling to help support people. Let's just finish with our traditional endings, which is what does better never ends mean to you?
For me, it just means fighting for those 1% improvements no matter what. I think clinically, there's this idea that if you don't get 100% in one go, you're a failure. And I think what people don't understand, just bringing it back to hypermobility, is that for people who have chronic pain or chronic health issues, a 1% improvement means so much. And if you get enough 1%, then you're going to be, stacking those 1% up and just seeing how far you can go. I think my personal health journey has simply been a experience of seeing how far I can go. And I try to support my patients in that way as well. So that's what better never ends means for me.
Very good. And if someone's reached this part of the podcast, they're clearly interested in what you have to say. So how does someone find out a bit more about you?
Yeah, it's really easy. So my website, hypermobilityhq.com, that is my kind of home base for everything that I do. If you need to get in touch with me, you can contact me through the contact form there. I am on Instagram and TikTok a fair amount. I'm getting on YouTube more often these days. I have a podcast. We spoke about this briefly at the start. I love my podcast, but I had a lot going on in the last year. So it's been a bit of a hiatus, but it was really inspiring to hear from you how you have previously had a hiatus and got back on the schedule. So I will be hoping to have that back soon. So people should be able to experience that again. And keeping an eye out for things that I publish. So on my website, you can get free downloadable guides and content. If you sign up for my mailing list, there are a ton of free resources that get sent to you. I also have my steady exercise guide for people who are hypermobile and looking to do cardiovascular exercise that might be appropriate for them. Of course, always speak to your doctor, but that's on Kindle Unlimited. And I do also have a book, which should be coming out shortly. It's called Help, I'm Hypermobile, your how-to guide for hEDS, HSD, and life in a hypermobile body. And it should, as of right now, be available for pre-sale October 1st, and then on sale, in the full sense of that word, January 1st, 2026.
And you said that book was a really easy process.
This is so sometimes I was doing a photo shoot the other day for, with patients in like a clinic setting, and the photographer's like, you look so happy. And I'm like, I am. This is like, seeing patients is the happiest part of my day. I love my work. It's my happy place. Writing a book is incredibly hard. I have to say, for anyone who's hypermobile and does a desk job and has to do a lot of typing, it's agony. It is physically challenging and demanding on my body. It's also just a whole process in and of itself. So I have a whole new respect for people who have written books. I have a whole new respect for people who have self-published to a professional standard, because book formatting and cover design and Amazon KDP and all these things, it is a whole process. So there will be a very good launch party in London at some point in the lead up to all this stuff happening, because I need it.
Congratulations, well done, inspiring, and I know where to go if I need to speak about potentially writing any potential books in the future. But you haven't necessarily pushed me to do that any sooner than I was originally planning, which was a long way in the future. So thanks so much for coming on. It's been a really great episode, and lots of things for people to go away and think about, and certainly even me, like I'm already planning on how to have conversation with people in a different way, and just the language. It sounds really important to get the language right. So thanks so much for that.
No, thank you so much for having me. It's been an absolute pleasure to be on, and it's always so wonderful to speak with people who are curious and want to help more patients, especially those who are hypermobile. So thank you.
And the podcast hiatus, by the way, this marks the end of a mini hiatus. So as much as we try to be regular every 2 weeks, these things are tricky to keep going. So yeah, don't necessarily hold that against yourself. It'll come. It'll be, when it's ready, it's ready.
Thank you so much.
Thanks for listening to today's podcast. This podcast is sponsored by Better, provider of health and wellness services in central London. We really believe that we can help people feel better and live better. You can book in for face-to-face services at any of our 3 London clinics. We have one in Marylebone, one in Soho, and one in the city. You can also follow us on Instagram at Better Never Ends, or head over to our website for more information about the clinics or the podcast at www.betterneverends.com.